Morning, everyone. I just forgot I haven't done my little ticker thing. Let me just get that sorted. Makes it easier to identify the videos. Sacral muscles. Let's just get that going. I thought something was missing. There we go. Episode 70. Yeah, I met some of you guys that I hadn't met before this weekend. It was the King's College London Anatomy Day, and spent the day looking at cadavers. Morning, Tris, and yeah, so it was a really good day and a fascinating talk on the cranial nerves, and a really unique way of teaching it that I'd never thought of before. I've never had it taught to me that way before, and every day I go in as well, I learn something new. Yeah, I will be stealing those teaching ideas and using them myself, definitely. Morning, Kat. Yay, good mate. Got to make a live. Neil, thanks for the tip about the market in Digbeth. I'll be going there this week. Thank you. Sarah, morning. Yeah, good to see you again, Sarah, on Saturday as well. I ate far too many calamaris at lunchtime with you. Stevie, good to see you, mate. So, Stevie, you're in for a treat on Saturday, mate, at Kiel. Looking forward to that one. Morning, homeschooling and Anatomy Monday. Would this be too advanced for a 7 and 4-year-old? Nah, no. What are their names? And I'll try and get them involved. Yeah. Cool. Well, so we've done. Let's do a little bit of a recap. We have done so far. We've had a look at the bony anatomy. Just get rid of that. Had a look at the bony anatomy of the pelvis. Morning, Michelle. Good to see you as well. Hope you enjoyed Saturday. What an eye opener Saturday was. Yeah. No, it's really good to see you again. I'm glad you got to go to this one because I think you were booked on the one before and couldn't make it, I think. So yeah, I hope you enjoyed it. It was really good. Good to see you there. Yeah. So we've gone through the bony anatomy of the sacrum. We've gone through the ligaments, and just want to do a little bit of a recap on those ligaments, and then we'll go into the musculature and some of the muscles that we were looking at in the hip and the pelvic floor are in this section as well. But obviously, we're looking at it now from a sacral end rather than a greater trochanter or pelvic floor kind of perineal area. And good. I'm glad you enjoyed it, Michelle. Good. I think it's one of those days where I don't know. It's just the weirdness of being there, plus everything that you see, and the guys that are there, the anatomists that are there that teach, just obviously do it day in, day out, and are just amazing. And you just come away and you're just a bit kind of, ooh, and it takes a little while to kind of let it all settle in and just think about things. It's one of those where I think you benefit, and this is by no means a sales thing. This is an education thing, but you benefit from going again because you've kind of got over that initial, oh, this is a bit weird, and then all of the new information where you go, bloomin' heck, I didn't know that. So then you go and have a look at it, and then you come armed. I think the next time you come, going, right, I want to have a look at that this time, and you've got a few more things that you're a bit more targeted in seeing. So yeah, if you felt a bit overwhelmed, or anybody that came, then that's entirely normal. And yeah, it is that kind of day. Good morning. Right then, let's get going. Yeah, so a little bit of a recap. Ligaments of the sacrum. So we had a look at this the other week, and we've looked at it before as well when we looked at the pelvis. So we've got these ligaments at the front, the anterior sacroiliac ligaments, and again, when you have it, we're not going to spend too much time on these today because we have covered them in detail. So you'll see on the videos from last week that although they're called the anterior sacroiliac ligaments, they're not like, they're merged. So it's not like there they are. It kind of merges into everything else that is around that region. And again, this is one of the things that's picked up, that when you look at the anatomy on a cadaver, you realize that the anatomists that put together the anatomy books have literally just sectioned off the body to make it a bit easier to learn. And really, that's not the way things work in real life. So everything, and I've said this loads of times, everything kind of merges in. So these ligaments are kind of thickening of fascia around that whole region that would cover that whole area. So it wouldn't be delineated like this. And there's a few times, on Saturday, where somebody goes, "Is this?" And you kind of have to look at it and go, I'm not really sure. Let's have a look. And you can't tell straight away what something is. But this is where knowing the anatomy is really useful, because what you can then do is you can literally hold that muscle or whatever it is, and you trace it back to where it starts or where it goes to, and then you can go, well, if that bit's going there and that bit's under there and that bit's there, then it must be that. And that's the way we do it. Even the anatomists, that's the way we do it. So sometimes looking at things just straight off, you need to, that's where knowing the origins, insertions, and everything that goes through it, I think that's where it's really useful. So this area obviously just covers the front of the sacrum. And then we've got this area then that covers the back of the sacrum, so the posterior sacroiliac ligament. There is a lot to process, Sarah. Yeah. And I was saying to some guys, I've been doing this over 10 years, and I still learn stuff every time I go. I still pick up stuff that I hadn't even thought of before, or that maybe I had forgotten it, but I just not remembered it or recalled it. There's a brain in that bucket, isn't there? Yeah, absolutely. Good. I'm glad you're looking forward to it, mate. No, it'll be a good day. Cool. Yeah, it's definitely not color coded. Well, I mean, you see images like this. Look, yeah. So we've got this. So there's your anterior sacroiliac ligament again, nicely painted yellow, and the ligaments, sacrospinous ligament and sacrotuberous ligament, painted yellow. And they're not painted different colors. They all pretty much look the same. Although saying that, there were some models that were actually very useful, and where they'd actually painted the nerves yellow. Like they are in the books. So that's quite interesting. And then we've got this one, the anterior longitudinal ligament, and we'll be visiting this one again and again and again as we work our way up the spine. So the anterior longitudinal ligament goes all the way up to the base of your skull. So you will see this at every single level that we work through. And we're going to do a similar kind of format for each section of the vertebra as well. One of the reasons why I've sectioned it off in this way is I did do lumbar and sacrum together, and then when we get to the nerves, you then do kind of lumbar sacral plexus. So there's a lumbar plexus, and then there's the sacral plexus with a bit of the lumbar attached to it. So that's a lot. That's a lot to take in. So what we're going to do is section off the sacrum, the sacral nerves, and we'll do that next week. And then we'll go through the same kind of process with the lumbar, and then section off all the lumbar nerves, and then join the two together. So that should make it a little bit more manageable to understand. And we'll do a similar kind of thing with the thorax as well, so the thoracic region, and we'll go into the organs in that region as well. And I did a session last year, but just purely on the heart. So we'll do a similar thing this year as well. So yeah, anterior longitudinal ligament all the way along the whole front of your spine. And then there's a posterior longitudinal all the way down the back of the sacrum as well. And that goes all the way up to the cervical region too. So we've got these really, really long ligaments. Sorry, just get rid of that. Really, really long ligaments that extend all the way up. So if we think about what these ones do, and it's worthwhile going over these again, because these ligaments in the lumbar spine, thoracic spine, and cervical spine, there are some additional ligaments as well. And I won't go over those right now, but there are a couple of other layers. and knowing the names of these ligaments will help you if you start to see MRI scans and things like that, because they will mention these ligaments in the scanning, and they will say whether they're normal or not. So if you see a scan and you're thinking, what the heck is that? Then this kind of anatomy knowledge will help you explain things to your patients, because quite often people will get an MRI report and they just sent it, and nobody really goes through it with them. So it's very useful for the therapist or fitness professional, whoever, to go through that. So yeah, when you Steve has just said, I'll just pop this on the screen actually. So when you think about all the connective tissue in this area, you can understand why the SIJ, I think that is, hardly moves. It's not supposed to. Yeah, I completely agree. And when you look at the musculature in a second, you'll realize that not many muscles cross the sacroiliac joint, but where it does, it needs to be an anchor point for things to move. Yeah, so that whenever I do any kind of therapy regarding the lower back sacroiliac joint region, I will. You'll always have a good element of success by not just focusing on the sacroiliac joint, because all of the structures that attach from the SIJ or the sacrum onto the hip and up into the lumbar spine, up into the ribs, if we can affect those areas, then it helps with the sensitivity and the movement available in that sacroiliac joint region. Okay, so yeah, there's so much more that we can do, uh, and also psychologically as well. If you can get someone doing stuff that they haven't been able to do before by understanding how that region moves, then that can really make a difference to someone. Okay, so yeah, that's perfect. Yeah, I thought you meant SIJ. Cool. So that's a posterior longitudinal, and then we've got these interosseous ligaments, and yeah, so you've got that big lump of connective tissue at the back, the posterior sacroiliac ligament, and then you've got the interosseous ligaments as well, so interosseous between the bones, and then at the front of it you've got the anterior longitudinal, anterior sacroiliac. So it's just a whole mesh of really tough connective tissue. And then we talked about this as well, the thoracolumbar fascia, and this is a continuation of the latissimus dorsi muscle. So this muscle up here, we haven't really talked about this yet, but the lat muscle attaches via the thoracolumbar fascia into your sacrum. Okay, and we talked a little bit about form and force closure last week. No problem. Hi Penny, good to see you. Cool. So yeah, we've got this though we'll cover a bit more when we get to the lumbar spine. Okay, so recap done. Let's have a look at this one. Okay, so some muscles that we've covered before, some we've seen before, some that we haven't seen yet. So let's go over those. So I'm going to split this into front and back. So there's a few muscles that attach onto the front of the sacrum and a few on the back. So the one on the front, or one of the ones on the front, is the piriformis, and basically it comes from the name of a pear, okay, because it's kind of pear shaped. So it's the form of a pear. And one thing that whenever we saw the piriformis in the labs on Saturday, everybody said, "Is that it?" Okay, it's not. It's not a huge muscle at all. I mean, the cadavers that you get in the labs are usually very small people anyway, because they're in their 80s. They're usually quite frail, so the musculature isn't that big. But the piriformis muscle isn't this huge thing that you think it is. Okay, it's quite interesting, and you can see the amount of tissue that is around this area and the proximity of the sciatic nerve to this area as well, which we've had a look at previously. So that's where your piriformis lies, around that kind of region. So just a bit of a recap. So anterior sacrum and onto the sacrotuberous ligament, which is what we've just had a look at. So it's that bit just there, so front of the sacrum. So really, the only bit that you could possibly palpate potentially is probably this bit right at the end here, and even then there's a load of tissue in front of that. So this is why we've stopped using the term piriformis syndrome, because well, as you've seen with the hip rotators, there are so many muscles on that posterior aspect of the hip that it's really impossible to say it is the piriformis that's causing that problem. Yeah, so we call it a deep gluteal syndrome now. Okay, so because it doesn't really change what we do in terms of rehab. Yeah, so the treatment rehab is usually very, very similar. Whether it's piriformis obturator, gemelli, whatever it is, we would do a similar kind of thing. So we don't need to name piriformis because we don't know it is, and we haven't got a clue. So there's no need. There's no need to. And also, I think that's quite nice in a way that it's something isn't to blame. It's there's a number of different reasons for why people get the symptoms in that area if they do. So yeah, so obviously this is the front view. So this is the pubis just here. So you can only access it posteriorly. So let's have a look at that. Just make sure we got the right one. Yeah, I think this is it. Yeah, cool. Here we go. Okay, so just to give you a bit of an orientation, and just move me out of the way. I think I've changed the settings on my camera, so I seem to be a bit orange today. I definitely haven't been in the sun. Okay, so here's your sacrum. There's your pubis, pubic bone just there. This is your hip joint or the coxal joint, coxal. If you're not don't remember that. There we go. So greater trochanter, there's your iliac crest, so that's your ASIS just up there, and then the sacrum on the front. So you can see the holes on the front here. This is when next week, this is where your nerves will come out, and we'll start to track all of those nerves and then join them in with the bits that we've done around the hip. Okay. So there's your piriformis. So it attaches all on the front of the sacrum, the anterior sacrum. Sometimes that's called the ventral aspect of the sacrum as well. So we've got these terms. If you remember back to the bony landmarks of the sacrum, ventral is at the front, and then dorsal is at the back. So if you think of dorsal as like a dorsal fin on a dolphin, then in the spine we tend to use ventral and dorsal, which is a bit annoying, a bit confusing. It's just the way it is. But you can also use anterior and posterior, and that's perfectly acceptable to do that as well. So yeah, just pop that there. So this is your greater sciatic notch, and it's separated by this ligament here, which is sacrospinous ligament. So your piriformis muscle will go through onto there. And this is what I mean by the sacrum needs to be a bit of an anchor for this muscle. Okay, because it attaches onto your greater trochanter. So through that greater sciatic notch, so from the front to the back, attaching onto here, and it's going to have a rotation component to impact on the greater trochanter, depending on which position the leg is in. But you need this bit to be solid for it to be able to pull on that bit. Yeah, does that make sense? So if this bit moved too much, and they both moved at the same time, you wouldn't be able to generate force in this muscle to bring about any meaningful movement. So like Stevie said earlier, this has to be pretty stable to be able to move things from. Yeah, appreciating how beautiful these dissections are. Yeah, that they are. This is why I go, do you know what? This is a really good one. And you have like the utmost respect for the people who've done this. You look at the ones in the labs, and some of the ones in the labs have been there for a few years. so they're a bit dog-eared, and they start to dry out a little bit, so the tissue quality is not that good. But these dissections are phenomenal. That this would have been painstakingly done over hours. Okay, and to have the forethought to video each section of it, because obviously we go through the layers deep and then come back out, and they would have had to think about that as they dissected things away, because as soon as you've cut something in a dissection, that's it, it's gone. So you have to be so careful working through each of the areas. So it's yeah, you realize the skill of the people that put this video together, definitely. So yeah, and there's your attachment onto the greater trochanter. Okay, so actually piriformis, again, one that we probably have heard about before, quite a common one. And in fact, let's just go back there. So if we have a look here, these are the nerve supply, and you might think, oh well, actually you might be thinking, oh, okay, yeah, I know that now. So S1, S2, so that's going to be your first and second holes in the sacrum, and then ventral means at the front, so it's an anterior. Okay, so at the front there, and rami means branch, and which makes sense because there's number one, there's number two hole, so the nerves come directly out of those holes at the front and go whoop into your piriformis. Okay, so the location of it will give you a clue as to where the nerve supply comes from. Sometimes it's simple like that, sometimes it's not, and the nerves have travelled quite a long way. Yeah, sometimes it's a simple one. Okay, so we'll have a look at that next week. So then the next one on the front that attaches to your sacrum or and coccyx is your coccygeus muscle, and we looked at this when we did the pelvic floor, and it doesn't really do much apart from provide a wall. Okay, so there's that bit doesn't move, that bit doesn't move. Okay, so this muscle goes between two, well, this bit moves 1 degree, this bit doesn't move. So your ischial spine does not move. So that doesn't really have a contraction element in terms of moving something, but what it will do is it when you have pressure on a muscle and it gets kind of distended in a way, so like a sideways stretch through it, that will be picked up by the little stretch receptors that are in the muscle. And as they get elongated, that muscle will then contract to provide tone, okay, or an increased tone, because there's always tone in muscles. So you'll get a contraction of that muscle, but it will be to stabilize or support the back wall of the pelvic floor. Okay, so it's not to move anything; it's just for stability. Okay, so Becky's just asked, having a week, or maybe a statement, I don't know yet, having a weak or no anchor would suggest why those with sacral agenesis would have gait abnormalities. Yeah, definitely. Yeah, it makes sense, doesn't it? Yeah. So if you've if you've got nothing stable to push off, then yeah, it's no wonder your body will find a way to move. And this is the interesting thing when you look at things and the way that someone tries to lift something, especially when something's injured or it hurts, they will find any way to make it look on the outside like the way it should look. Yeah, so they'll use all the different movement strategies to be able to do it. And as you watch that more and more and more, you'll see the way that people kind of cheat to do things. Sometimes it's just their way. Sometimes it's an antalgic way. So they're doing it because something hurts or something is not functioning quite as well as it could do. So yeah, sometimes you have to isolate things to identify where the issues are. And again, that's really useful for knowing your anatomy because you know where things go from and to. So if you have a look at this one then, so it provides structural support, and again, you should hopefully now start to get to know the names of the nerves and where they come from. So anterior rami, or ventral rami, so front branch of S4, S5, which makes sense because of where it is. Okay, so you're going to have a couple of little nerves coming out of the front of between S4 and S5 that supply that coccygeus muscle. Okay, cool. Right, let's just have a quick look at that one. Again, we did have a look at this on the pelvic floor, and it goes into levator ani as well. This one, so we're just going to have a look at coccygeus. So there it is there. Okay, so when you're watching these videos back, what I've tried to do now is, if I just try and pause it, and there. Okay, cool. So what I've tried to do is right at the top. Oh, it disappeared because I've got something else on my screen. Okay, I've put these. Okay, these up here. So that is basically taken from the PowerPoint slides. So you don't have to go back on the video and then back to this one, back to the PowerPoint, back to this one. So I've tried to put all of the information about the origin, insertion, and nerve supply onto the screen now. And I only kind of realised that I could do that on the, I think it was on the hip. So I've got to redo all my videos now and put that on. So there's your sacrum, just there. There's your ischial spine and the coccygeus. So that I put the images on as well, so you can work out where they are. So that's basically coccygeus in there. Okay, so again, it looks a bit different to what it does in the pictures. There's your coccyx. So it doesn't have a gross movement function, doesn't really do anything other than a stability role. And then that's levator ani, which is a different muscle. Cool, and that attaches onto your coccyx rather than your sacrum. Good, okay, so let's have a look at the last one. So this one's iliacus, and you're thinking, sacrum? I thought this was iliac fossa, but actually, that's what. If you're a bit weird like me, then you would think that. So this iliac fossa is just here, so on that inside of your ilium, but it spreads, okay? And again, it merges into that anterior sacroiliac ligament and into the sacrum. So it's not just on the wing of your pelvis. So it's alar of the sacrum. So if you look back into the first video on the sacrum we did, that's the kind of top part. It's like the wings of the sacrum at the top, and the anterior sacroiliac ligament, which we've just done a quick recap on. So there's a conjoined tendon with the psoas, but the psoas doesn't attach anywhere near the sacrum. That attaches into the lumbar spine, and then this is supplied by the femoral nerve, and we'll get to that because this is L2 L4, so that's lumbar 2 to lumbar 4. So when we get to the lumbar spine, we'll cover that. And we'll have a look at the arterial supply too. So let's just have a quick recap of iliacus, or iliacus. If you want to say it that way, then you can. Here we go. Just pause that there. Okay, so we've got lumbar spine just here. This one here will be your psoas. And then this is iliacus, and you can't really see because it's a bit dark on the picture, but this comes all the way around. So your sacrum is here, comes all the way around to the front of that sacrum, and then drops over the pubic rami, and then down towards the lesser trochanter. So let's have a look at that. There we go. So all the way there, and there's your sacroiliac joint just there. Okay, so there are some fibers that will go there, but it's quite a broad muscle underneath the inguinal ligament, and then wraps backwards onto that little bit there. So there's your inguinal or inguinal ligament, again, whatever you want to call it, and then they both join together, go backwards onto that point there. So that's your lesser trochanter. Okay, so another sacral muscle. Obviously, there's a large amount of connection onto the pelvis with this one. So it's not as if it's just attached to the sacrum, but there'll be parts of it on there. So again, another reason why we need this area to be fairly stable to be able to hip flex. Okay, because one of your most powerful hip flexors, your iliacus, has some attachments onto that sacrum as well. Okay, cool. Right then, so posterior now. So we'll have a look at the back of the sacrum, and hopefully you might have heard of some of these. So gluteus maximus. Again, we've covered this when we looked at the hip. Okay, so we'll just do a quick overview. So there's your iliac crest. and then it comes down onto the PSIS and then onto the sacrum just there. Okay, and then it attaches quite broadly. And I think this is something we covered this more on the hip, but this is something that people don't realize. It's not just onto that point, onto that greater trochanter. Underneath there is the gluteal tuberosity, and it's on the lateral aspect of the proximal femur. Okay, so basically on the outside and the top part of your feet, of your thigh bone. Okay, and that bit there is often really sore on people who have gluteal tendinopathies, and we think it's going to be around that greater trochanter and that's it, but actually it's in there too. Okay, so anyway, that's hip, and we've covered that already. So let's have a look at this bit. We're going to be interested in here where it attaches onto the sacrum, and remember, this is quite a clean image, so you don't see any of the posterior sacroiliac ligaments. So those would be on there as well. And the glute max will merge into that. And if you have a look at the fiber direction going up in there, the thoracolumbar fascia that we saw earlier today comes down that way, and the glutes go that way, and they meet. Okay, so they meet together and they cross the sacroiliac joint. And that again is that theory that I was talking about the other week about form closure. So the muscles from the lat, thoracolumbar fascia, and the glute all working together to create form closure. So muscle efficiency, I would say. I don't really like to use the word stability because it implies that something's unstable or unstable, and it's not. It's a solid structure. But those muscles need to basically work together to help propel you when you're walking and running. That's naturally how we do it. There's all sorts of theories with firing patterns and all that kind of stuff, and that's been completely disproven. So there's no such thing as a firing pattern. Everybody is different, and some people who don't have pain have a worse firing pattern than those that do have pain. So those kind of theories have been thrown out the window. So let's have a look at this. So posterior ilium, posterior to the posterior gluteal line, onto the sacrum and the coccyx. Okay, so it's another sacral muscle. Let's just have a look at that. That one. There we go. Here we go. Here. So this is underneath. There's your greater trochanter. That one there's your glute med. That looks like piriformis there, and then these will be your obturator muscles by the looks of it. That's your hamstring going up into the sacrotuberous ligament just there. Okay, so a bit of an orientation, and then there's your glute med over the top. Okay, so now last time we were interested in here, so you can see how low that glute med goes. That's the gluteal tuberosity. And we're interested in this bit now. So it's attaching into the posterior sacroiliac ligaments. And the thing that's missing from here is the thoracolumbar fascia. So that's been taken away in this dissection. But that would be connected across that sacroiliac joint line. Okay, so there's your posterior ilium, and it's attaching onto your sacrotuberous ligament as well. So there's your sacrotuberous ligament, there's your sacrum. So your glute attaches onto the sacrum, and it will go onto your coccyx as well. Cool. So Becky's asked a question. So coaching cues like clench your bum before lifting the hips into a bridge, is that pointless, or does it have merit? It depends. As everything. If it helps symptoms, then do it. If it doesn't, don't bother. That's what I would suggest. So if something is painful, and then by concentrating on doing that, they don't feel symptoms, so they're able to do that movement, then yeah, I won't worry. I think if you, the muscles that are available in that type of movement, the main muscles are going to be your glutes. So for going up into hip extension, so glutes and hamstrings. So if you have your knees bent, then your glutes are at a greater advantage than your hamstrings. So you will use some hamstring, but you will more likely be using the glute. So they will be using it even if they don't really feel like they are. So if they want to get that sensation, like to feel that clench, go for it. That's fine. But really, what should happen is they should feel that, go through that kind of process, and then once they know they can clench it and they can feel it, then forget about it and then just move. Okay. But I would suggest that it's hard to just move when somebody's really focusing on individual muscles. Yeah. There was a really good study that was done. Sorry, going off on one a little bit, where they talked about internal and external cueing. So and it was on it was to do with jumping. I don't know whether they've done it with bridge, but basically they tested two coaching methods and looked at the jump height of individuals with the different coaching styles. One was internal, so they internal cueing, so clench butt cheeks, push with your toes, trying to basically doing a counter movement jump. And then the other coaching was, I want you to jump as high as you can, and that was it. There was no other coaching. And the one with the external cue, jump as high as you can, they had a much better jump height than those that were given internal cues. So when there's too much to think about, then it often makes it harder to do. So it's it depends. Some people like to feel it, which is fine. But then I would say, okay, you can feel it, you know it's working. Now forget about it and just do it. So in terms of a bridge, I would just say push your hips to the ceiling or something like that. Okay. Cool. Yeah, no problem. Yeah, there's some really interesting studies on cueing coaching techniques. Cool. Okay. So yeah, I think that's pretty much it for the sacral side. There's but basically we've got all these really strong, powerful muscles. So iliacus on the front, glute max on the back, um, coccygeus. It obviously doesn't do any movement, but then your piriformis muscle as well, which again is a very weak rotator. So you've got all these. Well, if we say glute max and iliacus, very very powerful muscles in hip flexion, hip extension, both attaching onto the sacrum. So you need it, like I say, you need a stable base. Okay. Yeah, fearless, thoughtless movement. I love that. Yeah, really good. Yeah, yeah. Once you know you can do it, just do it. Yeah, really good. Cool. Yeah, I think. I mean, you'll hear it all the time. I mean, I've worked in gyms all my life, and you'll hear these instructors that just constantly talk to their clients and saying, "Do this, do this, do this. Think about this. Think about this. Think about this." And you just want to just push, just pull, and very very just a little hand somewhere just to say, you don't even need to speak. You just need lift their elbow up and just guide it for a couple of reps, and then let them go, and then they've got it. Yeah, you don't need to keep on cueing things over and over again. Yeah, that's really good. So we're nearly there. So multifidus. Absolutely. This is not one muscle. This is loads and loads of muscles. And this was probably one of my most favourite things that the guy, the anatomist on Saturday said. So there is a abdominal uh, test that tests the co-contraction of your transverse abdominis and your multifidus muscles. And the idea is that they are supposed to engage together. Okay, so we would feel someone's back, we would feel someone's front, and then we go, okay, brace, and then we'd see whether both braced at the same time. And the theory was that you could palpate multifidus on the back and the transverse abdominis on the front. And I said this to the anatomist, and I said, so there is a theory, and there's things that are taught where you palpate the multifidus to feel the engagement. And he looked at me and he went, well, we can't even see it, and this has been dissected. That is how deep that muscle is. Okay, and that is how hard it is to identify when the person has no skin, no subcutaneous fat. You've taken off the erector spinae group, you've taken off the lats, you've taken off the thoracolumbar fascia, and you still can't see it. Okay, so it's another one of those where you're like, okay, am I actually feeling these things? Yeah. So these muscles extend all the way to the cervical region and come all the way down to the sacrum as well. Okay, so let's just have a look at those. Little video on those. Get rid of that one. Here we go. So again, if you want to pause this, and then I've left the table on, and so you can see it and the image as well, so you can get that in your head there. Okay, so these are the little multifidus muscles. So there's a rib. That band there, that's your supraspinous ligament, and we'll talk about that as we get into the lumbars. So that is a ligament that sits on top of the spinous processes. And this video doesn't seem to be playing. Oh, okay. Well, that's a shame. It's just a still. Well, you get the idea. So if you can see, these are the muscles here. So these are the multifidus muscles, and they basically extend all the way from the sacrum all the way up to the cervicals. Okay. In fact, this is probably one of the ones where you don't need a video, thankfully. And then these ones in here, so not to be confused, these are intercostal muscles. Okay, so these are your intercostals. So your ribs are called costals. So the intercostals are in between your ribs. All right, that's why they're called that. So those are the multifidus muscles. And then the last one is this one. So we got erector spinae group. Now the erector spinae group are three muscles. So the erector spinae is not just one big muscle. There are three separate muscles, although they all merge into one. Okay, they go in slightly different directions, and they're split as they go up the body as well. So from the outside, you have, I'll just go up here. You have this one, iliocostalis, ilium, costalis, ribs. Okay, so it goes from your ilium to your ribs. Next one is longissimus or longissimus, however you want to say that. Again, the nomenclature is interchangeable. Longissimus means long. Okay, and that also goes from the sacrum onto the ribs, but higher than iliocostalis. So it goes up a little bit further. And then the last one is spinalis, which is the most medial, so because it attaches onto the spine, and that runs all the way up the spine. Then there's a little bit of a split, and then you've got spinalis muscles in the cervical region as well. Okay, so it's actually kind of several sections of muscle, but they're all given the same name. So let's have a look at that one. It's quite nice today because I've not had to cram loads in. It's not been really rushed. I hope it's been all right for you guys. Okay, so three muscles in one. So what I've tried to do, again, you've got the little table here. This is the image that you've just seen. Although annoyingly, this is on the right side and that image is on the left, but you get the idea. Okay, so we've got, you can see that there's the muscle tissue, and these are the tendons, okay, and the fascia that connects to it. So what's been taken off are the lats, and then the thoracolumbar fascia, which would sit over the top of this. Underneath that, you'll then have multifidus, which you obviously can't palpate. Okay, so there we go, all the way down to the sacrum. So I've just put those letters on there. So iliocostalis is the outside one, longissimus the middle one, and then spinalis in the middle. Okay, closest to the spine rather. So iliocostalis, longissimus, spinalis. There is a rude way of remembering this, and you can work it out for yourself. It's I like something beginning with S, and then you'll remember what those are. I like sausages. There you go. Okay. Heard the term paraspinals. Would this be this group? Yep, correct. Yeah. So paraspinals just means either side of the vertebra. Yeah, perfect. Yeah. So these are the but the multifidus is also a paraspinal. And then you've even got muscles that are deep to that called the rotatories. and those are paraspinal as well. So we've got these really, really small ones, segmental muscles. So the multifidus, they attach from the transverse process onto the spinous processes, go up either to the one above or maybe two above or three above. And then the rotatories do the same kind of thing. And then these ones, these are for extension and side bend. So if you contract both sides, they will extend your spine. If you contract one, they'll side bend you. Okay. Whereas the rotatories and the multifidus, they rotate. Okay, just because of where they go from and to. So that's what they do. So let's have a look at these. So iliocostalis, longissimus, and spinalis. And longissimus and spinalis go a little bit higher. So they've got a shared tendon on the sacrum. That's actually, yeah. So there's your spinalis, which is closest to the spine, longissimus, and then iliocostalis. Yeah, just there. Just move this so you don't get confused. Yeah, so this is your posterior or dorsal sacrum, so it attaches all around there. So this is the shared tendon, but iliocostalis will attach onto your lumbar spine. Spinalis, spinous processes of the thoracics. And then longissimus, the one in the middle, this will go onto your lower 9 ribs, whereas the iliocostalis is usually your lower 6 ribs. There you go. Yeah, lower 6 ribs just there. And it's a little bit more lateral. You can see the attachment point just there. So from outside, lateral to medial, iliocostalis, longissimus, spinalis, like that. Okay, cool. And they all attach onto the sacrum, on the posterior sacrum. And that's your sacrum. Okay, we've got one more bit to do next week, which is the adding on the nerves and the blood supply. Okay, so we'll see how we go with the nerves, and what we might do is do the nerves in one go, and then do a recap of the nerves if we cover them all, and then add in the blood supply afterwards on another session. So it might be the next 1 week or maybe split over 2. We'll see how it goes. Okay, cool. Thank you, everyone. Thanks for joining in, and I hope you enjoyed it. We are getting there with the sacrum now. So yeah, we're good. Like I said, we'll do the same for the lumbar spine. So next week, definitely the sacral plexus. Okay, so that as you know, whenever we cover the nerves, that's when it gets heavy. So make sure you get yourself a coffee, and I'll see you at 10 o'clock next Monday.